Thank you, Pam, and thank you everybody for choosing this session this afternoon. We know there are a lot of really wonderful sessions here today, and also we promise that the post-lunch lull will be combated by this really wonderful discussion this afternoon. We will have an opportunity for audience Q&A and engagement, so if you have questions and things that you want to contribute to the discussion, please be jotting them down as the discussion goes on, because we will ask you to contribute when we get to probably the two-third point. And we do have two polls that we'll do throughout this discussion. I'm Annie Kennedy. I'm the Chief of Policy, Advocacy, and Patient Engagement at the EveryLife Foundation for Rare Diseases, and it's really a privilege to be here today and to be joined by this esteemed panel who I will ask to introduce themselves to you in just a moment. But just a little bit of context for this session before we get started. As many here know, our newborn screening system is now more than 50 years old, and it is considered to be one of the most successful public health ecosystems and public health programs in our nation. However, despite many achievements of our newborn screening system, there are limitations to this current system, and many of us have experienced them firsthand. These limitations have caused significant delays between the availability of an intervention or a treatment and when screening is made available to families. And these limitations are putting infants and children at risk for preventable mortality and disability. Thanks to advances in diagnostics and medical technology, and many in this room and the work that many of you do, many rare but serious disorders that were previously considered to be untreatable are now, and may soon, have the potential for life-altering improvement. Yet the speed at which these potentially transformative technologies and treatments are being developed is at odds with our current newborn screening system, which is causing all of us to activate around opportunities to modernize. So that's what we're here to talk about today, and that's what many on this stage have been working on. How do we innovate, enhance, and modernize our newborn screening system? So I'm honored and thrilled to be able to moderate today's discussion. So I now have the privilege to introduce Dr. Wendy Chung, who serves as the Chief of Pediatrics at Boston Children's Hospital. And then to her left is Stacey Seeloff, who's the Director of Strategic Alliances at Rady Children's Institute for Genomic Medicine. And then to her left is Brooke Thomas, who's the Chief Programs Officer of Alabama Rare. So while everybody's bios are certainly available in the program materials, I would love to ask everybody to introduce themselves and spend just a few minutes providing a little bit of context for why each of you are here with us on the panel today, and maybe orienting everybody to your vantage point on our landscape specific to newborn screening. So I'll start off with maybe Wendy, if you could start.
Sure. So this makes me feel old, but I started my scientific career and studying phenylketonuria with Seymour Kaufman at NIH over 30 years ago. And with that, that was really what drove me to become a physician scientist and appreciate newborn screening. And then fast forward, in 2016, we started the pilot study for SMA newborn screening, which was part of larger, I think, important opportunities to, I truly believe, change what SMA is today compared to what it has been. And then we built upon that a newborn screening pilot for Duchenne muscular dystrophy, and I'm glad, I think everyone knows, but there's now genetic therapy for both SMA and DMD. And within that process, I realized it was onerous to be able to do those pilot studies, which were incredibly important, but a lot of work. And so I started thinking about how we could do this at scale and be able to leverage a new platform of DNA sequencing to be able to do not just one condition by one condition, but potentially add tens or potentially more dozens, hundreds of conditions for newborn screening. And that's what we're doing now in a pilot study called Guardian, Genomic Uniform Screening Against Rare Diseases in All Newborns. And so we're gathering the data to learn how to be able to do that and see whether that's worthwhile.
Fantastic. And when you say onerous, I think that's an understatement. So the platforms are so incredibly important. So we'll dig into that a little bit more in just a moment. Stacey, can you introduce yourself?
Certainly. So I work for Rady Children's Institute for Genomic Medicine, which is embedded in the Rady Children's Hospital ecosystem, which is the largest pediatric hospital on the West Coast. And what we're focused on is ultra-rapid whole genome sequencing for NICU and PICU babies, and we're finding about 30% of those kiddos are coming up with underlying rare disease, which is surprising. You know, it was unsuspected, but that led us to believe that, you know, what could we do to catch these kiddos before they become symptomatic and have irreversible damage? And so we've created a new program that's been running for a couple of years called Beginnings. And this is a broad initiative, and our aim is to advance newborn screening through whole genome sequencing and to make that standard of care for all newborns, similar to the Guardian program that Dr. Chung is running. And so my role at the Institute is I manage our consortium, our Beginnings Consortium, which is a broad collection of both public and private groups who are working alongside us to address some of the challenges and barriers that are standing in the way of making this a sustained reimbursable reality from a newborn screening perspective. And so I'm really here to invite all advocates and representatives for rare disease, as well as technology and data partners, and medical care team members to, if you're interested in joining the Beginnings program, would love to talk to you, and you can connect with me through the app or throughout the meeting.
Great, thanks, Stacey. And Brooke, can you?
Hi, I'm Brooke Thomas. First, I want to say thank you. I am incredibly humbled to be a part of this panel with so many, or these three, there's not so many, wonderful and inspirational women. The three of you are really just great role models for girls in rare in the future, so thank you for all that you do. So I am the programs officer at Alabama Rare. I have a couple of different titles within the rare disease and the disability world, but today the title that brings me here, the most important one and my favorite one, is mom. I am the mother of 3 children with MPS I Hurler syndrome. And then the second title that brings me here is friend, because no one advocates for newborn screening for their own children, right? We do it for the friends that we've yet to meet. I would say probably our first venture into newborn screening advocacy was with the birth of my second child. She was diagnosed prenatally, which is kind of like a bright star in the world, right? You have a birth of someone that's already diagnosed. And so that was when the advocates were really fighting hard to have MPS I added to the recommended screening panel. So she did a stack of heel stick cards, and they went out all over the world to help calibrate machines and test, programs that were really starting to launch then. It was a very easy way to step into the world of advocacy, at least for me, because it was not my heel that got stuck. But then really started focusing on how we could improve newborn screening in our state back in 2019. And I'll expand on that a little bit more, but spoiler alert, we did pass legislation this year, and we are certainly not finished.
First of all, I love that you also belong in the category of people who are extraordinary rare leaders, but also that you made the point that you're really always working to move the field forward for somebody else in newborn screening. I think that's really an incredible point. It's something I've always thought about, that if we do it right, those who benefit will probably never know that the path was paved by anybody. That when we've really succeeded, people will be identified, treated, and then move on, and maybe never even enter the communities that fought the fight. So I think that was a really poignant point to start off with. So now that we've introduced ourselves and you have a sense of who's up here, we would really like to have a great sense of who's in the room. So we are just going to do a quick poll, and if you could let us know who you are, by just letting us know, you would describe your experience with newborn screening as, I'm new to this topic, but would like to learn more. Your child was diagnosed through newborn screening. You're actively lobbying for newborn screening at the state or federal level. you'd like to advocate for your community around this issue, or you're currently working within the diagnostic ecosystem. So if you just take a moment, and we'll get a sense for who's here. Is there a QR code on a screen? What's the code? Do we know? Is it working for people? Or we'll just do it old school and we'll have you raise hands. Okay, we're going to do it old school. Is it possible to raise the lights a little bit so we can actually see people's hands? Are light switches available? Yes, no. There we go. Okay, we're going to go old school here. All right, if you're new to this topic but would like to learn more, and look, this way you can vote multiple times because people may be in multiple categories. If this is a fairly new topic to you, raise your hands. Excellent. If you're here because you had a child diagnosed through newborn screening. If you're here because you're actively lobbying for newborn screening at either the state or federal level. Love it. If you're here because you'd like to activate your community around this issue. I also appreciate the hands that go like this. We see you. By the end, you're going to be like this. And then you're currently working within the diagnostics ecosystem somewhere. Oh, great. Okay, great. Thank you, everyone, for being here. All right, and I think we're just going to disband with polling for the rest of this session. So. Okay, thank you. All right, so maybe we'll do just a little level setting with some definitions, because I think throughout the introductions we used a lot of terminology, and let's make sure, especially we had a lot of people who were newer to the space, that we do some definitions. So maybe we'll start, Dr. Chung, with you, and if you could maybe start by providing just a very brief description of what we're referring to when we're talking about traditional newborn screening that's delivered through the public health system today, traditionally.
Sure. So you may or may not remember, but your baby was probably had a heel stick where we got a few drops of blood. I say we in terms of the healthcare community. They put those drops of blood on a filter paper, and then depending on which state your baby was born in, they went to a state newborn screening facility, and they screened for, depending on the age of your child, somewhere between 25 and 50 conditions is the greatest likelihood, unless your children are really old. All of that is provided in part of the public health system, meaning usually that's covered by the state system or in some states by insurance, but it's covered for everyone is the point. Every single baby gets it. They usually get it before they go home from the hospital, and usually the results are normal. But in about currently 1% of babies, there's a result that's positive, screen positive, and your pediatrician would have been notified to say there's a problem, you need to come in for a confirmatory test or additional testing. And all of the conditions that are included because it's news you can use. In other words, these are conditions that are readily treatable, there's good treatment that's available, and early diagnosis is important to be able to prevent long-term problems. So conditions like that, the poster child for this I mentioned earlier, phenylketonuria, that can be associated with intellectual disabilities if it's not diagnosed early, but if it is diagnosed early, you can be put on a special diet and you can have a healthy life. And so that's the point, is that we want to make the diagnosis for everyone at a stage where it's treatable, and we don't want to leave anyone behind. So hence the good utility of a public health system for making sure everyone has access to diagnosis and treatment.
Great, thank you. So maybe, Stacey, you can then layer on top or complement this by then talking about what is genetic sequencing in the context of newborn screening.
Sure. So genetic sequencing is where you're actually looking at the entire genome, and I'm going to use the word genome here, where we're sequencing the entire DNA of an individual. And it's important to note that there's two different frames of view that you can take when you actually do the full sequencing, and that's either a diagnostic view, where you're actually looking and analyzing the entire genome, looking for things that might explain a specific phenotype in someone who's acutely ill. So that's a diagnostic genome. In the newborn screening area, we're really talking about a screening test. So even though it is based on a whole genome backbone, meaning that we're sequencing the entire DNA strand, in that case, we are informatically looking at only certain sections of the DNA. View it as like picture frames. You know, it's maybe like a 5x7 versus a panoramic view. And so most of the programs that are doing genomic sequencing in a newborn scenario are focused on things that have childhood onset, that have treatable or actions that you can take based on the results that you're getting, so that you can actually follow up or put those kids in follow-up care. So it's not diagnostic at that point, because there's still confirmatory testing that has to take place in order to truly diagnose that individual, but it is screening. And so there is a difference in terms of diagnostic rates between a full diagnostic genome, which, as I had alluded to earlier, in our experience at Rady Children's Hospital, we find that about 30% of the kiddos that are acutely ill are finding an underlying rare disease, whereas in a screening application, we're really thinking that only about 3 to 5% of the individuals who get screened are going to have a positive test that then requires follow-up. So the intended populations are very different between a diagnostic sequence versus a screening sequence. So I just wanted to kind of make a level set and make that clear.
And so before we move to Brooke, who's going to talk about, I'm going to move to a new concept in a second, can we just talk a little bit about the distinction between what Beginnings is doing and then Dr. Chung, what you're doing with the expanded panel for sequencing in the newborn period versus sequencing in the NICU? Can you just talk a little bit about why those are both so important, but both are very different? So maybe the two of you can decide how to navigate that.
Sure. Dr. Chung. I'll talk about maybe the diagnostic genomes that we're doing. So the intended population there are acutely ill kiddos that are presenting in a NICU and a PICU environment. And so these are babies that the physicians aren't suspecting a genetic disease in that case. Otherwise, you know, they would go down a certain path. But we will do ultra-rapid whole genome sequencing in that case. Usually within 3 days, you'll have a result. And I also wanted to iterate that sequencing once doesn't necessarily mean that you're always going to find an answer. And so as technology advances and as the bioinformatic tools advance over time, sometimes it's necessary to actually repeat or rerun the sequencing so that new things are discoverable at that point. So that's a diagnostic whole genome sequence that we're referring to in that context. And then from a screening perspective.
So for the screening perspective, and sometimes this is or isn't a difference, in the screening perspective, we only look at the genetic information from the baby. Sometimes in the diagnostic mode, we'll include the parents as well to help guide us in terms of the answer. But for newborn screening, it's just the baby. And there's a big difference in terms of, we call it the priors, or the prior probability. So in the diagnostic setting, because the child is sick, there's a higher probability that we're going to find the answer. And in fact, as you said, 20 to 40% of the time we will find an answer. When it comes to the newborn screening, it's everyone in the population, and thankfully everyone in the population isn't going to have one of these conditions. So the probability that there might be something is much lower, more like 2-3%, depending on exactly what you include in this genetic screening, and different studies are including different things. The important part that you alluded to already, but just to sort of underscore it, is a screening test is just a screening test. So for any of you who might have gotten, for women, a mammogram, for men, a PSA screen, when you do those, just because they see something on your mammogram doesn't mean you have breast cancer. They need to go and do an additional study after that to make sure that it's the case, a diagnostic test. And it's the same thing with newborn screening. It's kind of the first stage in here, seeing if there might be something, and then doing a confirmatory diagnostic test. But I will say, and for those of you, which is I assume most of you who are parents, that time between when you get that first phone call about there might be something and then you've got to do some additional testing is an unsettling time. And so that's one of the things that we need to make sure that we're doing well within this, is not have false positives or things that we're throwing up alarm bells and then it's much ado about nothing, because that's not a good experience for a new parent to have.
So thank you. I think that's really incredible clarity that you've provided. So Brooke, let me move to you, because really across the nation, our patient advocates are really transforming the landscape by driving efforts that are helping to move conditions onto the federal recommended uniform screening panel, and then very importantly, moving conditions into state implementation. And this is something that you have helped to lead with partners at Alabama WIR. So can you talk a little bit about your experience?
Sure. So I think it's really important to start out with, I think we all know that Alabama is a very rural state. It's very economically disadvantaged in the majority of the geographical locations. If you are not in one of the 3 population centers, and really you could put that down to 2, then it can be next to impossible for families to even have access to the kind of diagnostics that Dr. Chung was just speaking about. So Alabama WIR's path to legislation really began at a State House event back in 2019. It was just a broad rare disease awareness kind of day, but several of the attendees were really poised to make newborn screening kind of a priority and just chuck that up to Providence. There was a mother of a child with SMA, then myself with MPS 1, and my oldest son was there, and then we had a neonatologist from one of the rural areas of the state that was also there. And we ended up kind of moving into being the advisory committee for Alabama WIR with newborn screening moving forward. So we really started digging into what newborn screening looked like in Alabama, and that in of itself was a difficult task. We did find out that it was taking 7 to 9 years for diseases to be added at the state level after they were added at the federal level. So we've already got this layer of patients, families, babies being born without access to geneticists or genetic testing, and then kind of the blanket protection that we're supposed to have is also failing our families in the state. As a mom, so by that time my kid's disease was added to the federal guidelines, and as a mom that just made me livid. Like, this is unacceptable. We can't do this. And then COVID hit, of course, and we had already made some friends in the legislature, and so they really advised us, just kind of hold off. You can't push the state health department during COVID, right? Then you'll be the bad guys. But we joined the newborn screening advisory committee that the state has, and so they meet biannually, and every meeting they would give us another excuse why they weren't adding the missing diseases, and it would get pushed back 6 months, and this just continually kept happening, right? So finally, by 2022, I'll admit I had a little bit of a temper. I said, no, we can't use this. I don't want to say excuse, because COVID's not an excuse, but we can't use this as a reason anymore, right? We need to move on. You're a health department. It's time to do what you need to do. And because the federal guidelines were evolving then, they were adding new diseases at the time. So 2022, we really started laying the groundwork for our legislation. Not sure if any of you heard, but politics in Alabama can be challenging at best. So I won't really get into all the specifics right now of what we did, but for all of you that are actively working on legislation, I'm more than happy to share with you the path that we took and what we did and what we learned. I will say that our roadblock was always the Department of Health. The legislature was behind us 100%. Our bill moved through both chambers unanimously. It was always the Department of Health.
I think one of the things that's super interesting is that state legislative efforts are so different from state to state. So I know in some places the state health departments are the biggest champions, and then the legislatures are barriers. So I think it's really important for advocates to be exchanging experiences, but also incentivizing the state health departments to be working together and learning from one another, because your experience really speaks to that. So, which actually segues beautifully into the next thing that we wanted to talk about. So we're going to really wave a proverbial magic wand so that we can really focus on the diagnostics aspect of our ecosystem, and we're just going to pretend that reimbursement is not a real issue when we think about therapies that would be available once we identify individuals who would benefit from screening and be identified as having a rare disease. And so what I'd really love, maybe we'll start with Dr. Chung and Brooke to maybe think about, can you talk a little bit, let's build off this public health system and where some of the bottlenecks are, and think about how could improved understanding of the benefits of timely diagnosis and early intervention in more rare disease spaces, how could that really benefit our efforts within the public health system? So more specifically, can you talk about the impact that having conditions added to the federal recommended uniform screening panel and the timeliness and state addition, the impact that's having? What do those bottlenecks actually look like in real time in the various different elements of the ecosystem in newborn screening from your various vantage points? It's a long build up to the question.
So to build off what you said, I think it's really important that every state lab is different also, and how they're run, how they're funded is all different. So in Alabama, their primary problem, they said, was staffing. We know from talking to other labs that some of the primary problems that they would have would be acquisition of equipment. Maybe they were legislated in a way that they couldn't just go out and buy the equipment that they wanted to have. But what really helped to move us along, we have a girl that was diagnosed in our state after NPS 1 was added to, which is what my children have, after NPS 1 was added to the federal screening recommendations. She was missed. She lived in a very rural, very economically disadvantaged part of my state, and there are no on-site geneticists south of Birmingham. So geographically, Birmingham is kind of north central. So really, larger land area of the state, we have no on-site geneticist, and sadly, she was not diagnosed until her window of opportunity for treatment had already passed. And this effectively cut her life expectancy in half. So you go to a state health lab and, you'll get the runaround, but you put a picture up and you say, this is what happens when we aren't effectively screening our children. And it also worked in the legislature. I don't think I actually answered your question, but I wanted to make sure
you did a great
story
job,
got
actually.
Because that was obviously it's heartbreaking and it's unacceptable that this happened, but it was huge in pushing our efforts forward and kind of skipping those bottlenecks.
But maybe, you actually opened up a few other areas that I would love to hear everyone comment on. You, in your story that you just spoke about, you also really touched on workforce issues that we have, the inavailability of specialists. So maybe if you could all talk about, it's one thing to have technology, it's another thing to make the information that technology is enabling available to the providers that have to deliver it. So can we talk about what that system is beginning to look like? How do we deliver it to the providers in time to inform the interventions in a timely way?
I don't think you want me to answer that because Alabama's
well,
not the gold.
Let's start here and go this way.
So I'm going to take the magic wand, Annie, and
Okay.
this is in my fantasy world.
It's now a magic baton.
Yeah, a magic baton here. So I think this actually works for newborn screening, and I would argue that it works for each of the communities that you represent today, even not on newborns, and that's the following. So the good thing about having this single platform of DNA sequencing is you can have a distribution of experts in terms of both interpreting the information and then how to support those individuals with rare diseases. And there's enough technology, because virtually people like me can drop into visits and to be able to bring our brains to the bedside, if you will, really around the world. Now, there are some regulatory issues, and this is where you all can actually be helpful in terms of making a movement to increase access for this. But people can, around the world, people can be able to contribute to the interpretation of the information, get the right diagnoses to the right people. And then I'll also challenge us as a rare disease community that once that person is diagnosed, whether they're diagnosed from newborn screening, whether they're diagnosed from diagnostic testing, however it is they're diagnosed, they now need to onboard to the right care. And within rare diseases, one of the challenges is that most doctors have never seen an individual with that condition. How could they? There are, depending on what you want to say, the count is 7,000 to 10,000 rare diseases, and there's no way you could have learned that many when you were in medical school, nursing school, whatever it was. But you need to get that just-in-time, most up-to-date, most accurate information to that person, to that family. And so how can we as a community collectively then be able to just in time come to the bedside virtually? How can we be able to have standards of practice that are freely available and constantly kept up to date? And how can the rare disease communities know where to be able to get that? And then phone a friend. And so can we have a network of those friends who can help support those individuals? How can we empower you all to be able to have that information at your fingertips and get it to your communities wherever you are around the world? And I would argue that if we could take care of some of the regulatory issues that with COVID were relaxed, where we could now start to provide care across state lines around the world, why can't we come back to that state again in the rare disease space? And I do think that as we do that, we can also teach local providers how to care for those conditions so that we're training the workforce to be able to do it to support your communities better. So that's what I'd like. That's my wish.
And maybe to expand on that a little bit, my wish would be that there is almost like a feedback loop, so that as the medical communities and that care gets delivered, that there is information flowing back into the system that says, okay, how was that treatment received? What was the outcome for those individuals? So that we start to learn, collectively what works and what doesn't work. It can feed natural history studies. We get much broader ethnic and racial participation, which helps from an equity perspective. There's a lot of benefits, I think, that can come from collecting this data in a very thoughtful and specific way.
Can I ask a question about that? I'm going to be really provocative for whatever time it is, 2:30 in the afternoon. When it works really well, ideally, again, I'm holding the magic wand right now, we've identified somebody pre-symptomatically or early enough that we've had a very successful intervention that has enabled somebody to live almost symptom-free. And so, yes, Stacey, 100%. We want to be able to collect long-term data to understand how well they're doing and that long-term outcome. How do we incentivize people, though, to continue to participate in a healthcare system and in data collection efforts when that individual who was identified as a baby, received intervention, goes on to be a healthy teenager, a healthy adult? Listen, I have an almost 14-year-old, he's not interested in doing half of what I want him to say, let alone participate in extra visits that may not have the value proposition that it would have had otherwise. So, and I know we're seeing that already in some communities where we're starting to lose people to follow up. So I'd really be interested in the thoughts of folks of how do we incentivize that, or maybe that's a challenge for the rare disease community to think about. As the natural history changes, we also have to think about how we change and update and enhance the incentives for continued participation for the community, because it's going to have to look different.
Absolutely. I don't know that I have a magic answer for you on that one, but it does. It's an interesting concept, because if you catch someone pre-symptomatic, do they even identify as a participant in that community,
right,
any longer?
Yeah.
Which is an interesting thought. So part of me thinks, do we have to rely upon the greater good message in terms of, be involved to help, the broader community at large. But, I'm not sure how effective or how much that penetrates into the audience.
Yeah.
So I think we're living this with SMA.
Yes.
So SMA is relatively new on the scene for doing this and with newborn screening. And while I think the treatments that we have are infinitely better, they're not perfect. And I don't know that everyone appreciated that. And so Cure SMA has worked hard in terms of making a national registry, and you really can theoretically get population-based ascertainment and outcomes to truly know in a collective way, and also start to look at things like social determinants of health and location and how that plays into outcomes. And it's not just about the diagnosis, there are many other things that complicate it. So I'm going to take the magic wand prerogative again, and I happen to be talking to Epic about this morning. So I do think there are possible solutions. So I always ask the question, what's in it for me in terms of doing this, and how can we decrease the friction in the system? And I do think that if you think about where many people are getting their health care, it's in a system where Epic, as the electronic health record, contains a lot of that information. And there are a relatively small number of SMA providers, and so you can onboard everyone to this because there are a finite number of nodes that people need to go to get their original treatment. If individuals could then passively provide their data lifelong, they have consent to be able to do this, they say, yes, I'm going to donate my data through Epic, you can have it, but don't bug me. So just do this, you can take it in, and at some point, as you learn about this, to your point of the learning healthcare system, as you learn about this, I want to know about this, send the information back to me, but don't bug me. I bet we could do that with a way that's not too expensive, not too painful, because it's passive from the participant's point of view. And if they want to do more, they can sign up for additional studies to that, but at least you'd have the minimal data in terms of getting outcomes to figure out, is gene therapy, is ASO better? Do we need to use additional medications? When do you need to rescue someone? But there are still people with suboptimal outcomes identified from newborn screening with SMA. We're not perfect yet as we're doing this. And so I think we've got to identify those gaps.
Love that. I think we're open to audience questions. So, and we have some. That's great. So can I
make one little point in?
Yes, absolutely.
I also want to say what's in it for you all, and I've seen this from pharmaceutical companies, and I really want to emphasize this. They are looking for essentially their market of patients for the future and wanting to be able to identify the patients that would eventually benefit from their products that they're developing. And this idea that newborn screening may provide that group of patients, number one, a lot of people easily identified, and at a stage that's treatable, it de-risks it for them in terms of thinking about developing treatments. So part of the reason you all want to advocate in terms of this is self-serving, to be totally honest, because it will drive companies to come into this space that otherwise would not be willing to enter the space. So I hope all of us will think about that in terms of what's in it for you as well. Sorry to interrupt.
No, not at all. Can we turn the lights up just a little bit so we can see who's asking questions? And then...
Hello. Hi.
Can you introduce yourself also?
Yes, thank you. I'm Nicole Lytle with Rare Birds Foundation, as is Stacey. So we have no children in our group that are African descent. I don't think that can be true. So I'm curious a little bit about whether the newborn screen takes that into account. I understand that diagnostics are off because of the genome is primarily towards people of European ancestry. So is that true with newborn screening? And what are some workarounds for that are in process or coming in the pipeline?
So you packed a lot in your question, which is amazing. So I will just first say that one of the advantages do you have a condition that you're starting to develop evidence around to move it towards newborn screening? Okay, which is terrific. So one of the advantages once a newborn screen is added to the public health system is you start to get a better look at the true incidence of your condition. And so that helps not to completely eradicate, but does help begin to eradicate some of the disparities that we have in who's identified and when community members are identified. with different subsets of rare diseases. So that's one of the really important drivers of wanting to move conditions towards the public health system and towards public health identification. So that would be the first thing I would say, and there are some really interesting studies that are beginning to come out. Pure SMA actually just put out a report actually coming from their registry looking at how their demographic has begun to change now that newborn screening has been added in all 50 states. So there are some really nice studies starting to come from some of these communities. But I will actually turn it over to people who are much smarter about genetics to answer some of your other questions that were packed in there.
The echo is a little weird in here, so I'm going to repeat what I think was the question, but I'm not sure I got it right. So if I understood part of this, interpretation of the genetic information is not equitable for people around the world. Was that part of what was embedded in there? Correct. So there is a challenge that we will get better over time, and it actually is a positive feedback loop, that the more people we sequence from the four corners of the world, the better we get at interpreting it for everyone, actually. But there's a time that it takes to ramp up, and it's important that we're very inclusive in terms of these early stages with it. But there will be disparities, and I can see it in Guardian now. There are disparities if you're Black, Latina, white, Asian. It takes us a different amount of time. We're accurate with a different rate. But it's important, and one of the things I want to make sure it's clear, it's important that we're inclusive for the conditions we put on these screens to be global in terms of thinking about what we're including, because some of the recessive conditions have very different frequencies around the world, and we shouldn't be doing it, in my opinion, just because it's rare in one part of the world, as long as it's treatable. As long from the newborn screening perspective, it fulfills those other criteria, it shouldn't be based on frequency. That's my own personal opinion. Mm-hmm.
And just to add to that a little bit is what we know about rare disease is changing based on the more sequencing that is done. Just speaking from a Rady Children's Institute perspective, the Kabuki syndrome, there are 400 cases in the medical literature, but within the first 500 genomes that we did at the Institute, we found 13 cases. So that just kind of blew the prevalency rate sort of out of the water in terms of, what we thought we knew about this is really not holding up to be true. So rare is not that rare anymore. And I think once we start sequencing at a population level, we're going to learn so much about true incidence and prevalence rates on some of these diseases. And, to Dr. Chung's point, we're going to learn a lot about the demographic and the variants that are present in certain populations, and that'll help us get faster and be able to do this sequencing interpretation at scale.
We have a question here.
Thank you. For an organization that's just starting to look into this now that we've got some favorable treatment, where do you start? Do you start at the federal level, or do you start at the states? Which comes first? And is it still 7 years to get something added to a panel?
So that was Alabama. Annie can probably speak better about how long it takes. It can still take several years at the federal level, which is where you would start. Now, some states will add diseases that are not on the federal recommendations. It just depends on your state, really. But Annie can.
Yeah, so I'm with the EveryLife Foundation for Rare Diseases, and we have a newborn screening action center and a boot camp that we actually provide resources to advocates who are looking to get started and develop the evidence to move conditions forward. And we can help you also with some decision tools as to whether or not you want to start with collecting evidence to move to state and federal edition, or whether you do want to be collecting statewide data at the state level. And then also to look at conducting pilots in states and how you start to develop that evidence and work with partners. So there's a lot of resources available and a lot of other wonderful advocacy groups, some of which are in this room, that have done a lot of that work that we can help connect you to. There's someone right up here, Pam.
Thank you. Hi, I'm Frankie Herrera, and my question is going to be, what would be your advice to this situation? So I'm going to take that wand from you. So I'm a mom of a child with 16p 11.2 deletion, and I'm a primary care physician. And my dream for caring for this condition is what I've seen the last 7 years, experiencing it with my child, is more than just the medical aspect of it, it's all of it. And so what I want to do is to have a medical model where people with this rare disease come to one location and you bring the specialist to you and they just give one day and see 20, 30 children, give all of their recommendations in a big kind of committee type. So you have your geneticist and your neurologist and your OT and your PT and your speech, and they give all of their recommendations. And then you have one provider who's maybe in primary care and has, some experience in this field. And then they spend the next 6 months making sure that all those recommendations are implemented, helping them advocate at the school level, IEPs and all of that, and then come back again 6 months later or a year later. What do you think about that? What advice can you give someone like me, who is one person who's trying really, really hard to get this moving forward? What advice would you have for me, or if there are any other advocates or people who are interested in this idea to talk to?
I think that's a wonderful idea. I would love to have the same situation with my kid's disease. Sadly, that's not the case, but.
Yeah, I mean, I would just say yes, yes, and yes. There are a number of communities that have done that very successfully. And we'd be happy, again, to connect you to some of them. I guess my first question, and we can follow up on this, is how many known patients are there in the US? And would you maybe even think about having multiple sites in the US so that you reduce some of the travel hurdles? You could identify a couple providers and create a network so that you maybe had 2 or 3 networks, which would reduce maybe some of the load for even the professionals. And then also you're creating a professional community, which might also incentivize development, some early clinical trial work, and even starting a natural history study might be a way to even spur the field a little bit further. But I know Dr. Chung has participated in some of those models as well, so she might be able to speak to her experience as one of the providers.
It's a fabulous idea. And in fact, part of the reason some of you know that I recently moved to Boston Children's Hospital to become chair of pediatrics, part of the reason I made that move was to figure out how to implement your plan, because I believe that that is what kids deserve, and how to be able to scale that as we think about nodes around the country to be able to do this. So I think it's a great idea.
And one of the trends that I've observed from my seat is the formation of precision medicine clinics in several healthcare settings. They're not widely available, I would say, across the nation, but I am starting to see more formation of these precision medicine clinics that are being created specifically for your purpose of, a family gets a result, and then the next question is, well, now what? And so these clinics are formed with the sole goal to, coordinate the supportive services, to follow kiddos on treatment, and to really help standardize, some of that follow-up activity. I know Rady Children's has a precision medicine clinic, and we've been very active in terms of working with other centers across the U.S. who are interested in also establishing a precision medicine clinic. So we're by no means the only group that's doing this. But I think even the coordination of healthcare systems is important, because we can all learn from each other in terms of what works, what doesn't work, and those kinds of things. So it is an emerging trend that I've noticed.
I would say that it could also come from a specialty that you don't expect. So we don't have exactly what you proposed, but my children are all treated at the University of Minnesota, and our metabolic transplant specialist kind of manages, oversees our care. We go to him for everything. We still see him even though we're 15 years post-transplant. So it can look different and still be as effective.
You don't need a magic wand for that, but there are people who can help you build it. I love that.
So my name is Craig Fishman. I'm from PacBio, and this is a general question. So we hear a lot about what exactly does everyone has a different view as to what a newborn screening test would look like. So in the theme of having a magic wand, if you had a magic wand and you can create the perfect newborn screening test, what would it look like?
So this is having done this a little bit. From a PacBio point of view, I think I just heard where you're from. So from the sequencing, that's an important first modality to do this, and I'm going to speak a little techno-speak that some people can take a nap for, but being able to use long-read sequencing technology and being able to see things that other technologies can't is definitely good. We need to be able to drive, it needs to be done on a dried blood spot. It needs to be a low enough cost that you can do this at population scale and that you can do this rapidly enough. And so those are some of the technical parameters. But to me, the ideal would be to have an orthogonal test embedded within that same dried blood spot as well, which won't work for all conditions. But the more you can do that to decrease your false positive rates with a tier 1 and tier 2 test, the better a test performs and the better it is for families and providers receiving those results.
I always feel like I'm adding on to what you say. But one of the other things I'll add is that there needs to be some bioinformatics support on the back end of that. To truly do newborn screening at scale, we're going to need machine learning. We're going to need artificial intelligence to help us do that initial round of interpretation. We're not going to get rid of the human support that's going to be required to really fine-tune the results, but there is going to be some major development, I think, that's going to be required in order to truly get this to a newborn screening scale.
And then you're going to have to make sure that you have a really robust follow-up program, because you don't want to just hand someone a diagnosis and then walk away, right?
Brooke, can I ask you to expand on that? Because we haven't talked a lot about that on this panel. Can we just spend a few minutes talking about what does that mean from a family's perspective?
So, not myself, my children were all diagnosed after it was added to the newborn screening, but in my world with these friends that I've talked about, I've heard horror stories. I mean, just the absolute worst that you can get. Reading a diagnosis in your patient chart online before they even have a chance to contact you. This is not my state, but another state's follow-up. This is newborn screening program leaving a voicemail. So actually, my disease society, the National NBS Society, has a fantastic program. It's called the Pathways Program. And the trick is, first you have to learn about the society. But once you are connected to the society after you've just been diagnosed, they will have a social worker fly to you and come in your home and give you your treatment options, tell you, the centers of excellence for any type of NPS that your child may have been diagnosed with. And I mean, ideally, I would like for that to be a state office, right? After these people are diagnosed through newborn screening, then you have a state health officer, nurse, social worker, not the state health officer, sorry. You have a social worker or a nurse come to you and give you your options, let you know, hey, life can still move on after this.
One of the things we've talked a lot about are, how advocacy is helping drive conditions getting on to the RUSP and getting, all the wraparound services that advocacy can offer. One of the things, though, that we worry about in the advocacy community is that oftentimes when people are receiving the diagnosis and receiving information, and the state lab provides the information to the providers don't know about the availability of the resources with the advocacy groups. And so then families don't get connected to the exact entities that have created all of these resources and drove the fact that the condition was added to the screening panels. And if that family doesn't get connected, as you were saying, to the Pathways program,
right,
they get caught then, and they fall down sort of this trap. And so when we were talking before about a magic wand, if I had a magic wand, when you were with that primary provider, who, as Dr. Chung was saying, primary providers don't learn about most of these conditions, just like when you go get your immunizations, your child goes for their well visit, up pops information about what immunizations your child's due for. When you would go in with somebody who was diagnosed with a rare disease, up would pop information about resources that that provider could provide to that family, all the different organizations that might be a resource. You could just print the page out, and then the family could decide who to connect with, but they would at least get that information. And to me, there are systems in place already. We don't have to create new systems. We just have to figure out how to integrate our newborn screening system into them. So with that, we were just going to ask a lightning round question to the panel and ask everybody, so thinking big, and there were some big things we've already talked about here. And I was writing down some of them, and I appreciate when everyone's like, and this would require regulatory change, which that's like speaking my love language. But we had the virtual expert access, and so thinking about how we could make sure that you had experts virtually around the world, sort of dropping in wherever they were needed for patients and providers. We had just-in-time standards, practice standards that would be available, and how do we make sure that those experts and the clinical experts and the patient experts who are helping to develop them would be able to have those published and made available in a way that they'd be available to the providers that were needing them. And we talked, and Dr. Chung used COVID as an example, that we were able to relax some of the standards that were required in order to make them provider standards, because we were learning as we were flying the plane. And if we could be thinking about that for rare disease as well. And then we talked about the need for a feedback loop and data collection, and what are we learning about the outcomes of individuals who are having early and more timely intervention, and how do we ensure that we're learning from that and improving on that, but then incentivizing folks to participate in that. With that though, if I can ask the panel, if there were a place you would start, what would you prioritize? What would you do? If we really did have a magic wand, you could wave it and remove a bottleneck in the system or add a resource. What would you use your magic wand for?
So this will sound self-serving, but I think it's self-serving for all of us. We've done a little over 12,000 babies in Guardian, and I have a sense that it can work. The problem is, as I said, the way things are set up now with the recommended universal screening panel and review, we've got to diagnose one child with a condition to be able to get nominated. And so how do we get from doing this many to doing this many so that we're not leaving any rare disease behind as we're doing it? How do we get the evidence to go forward? It's not, we know how to do it. It's just a matter of doing it. Like, just do it. We're going to be Nike ads, but so that's the stage we're at now. So if I could, I would get Nike to do it for us.
And then from my perspective, I think a really important thing is that the newborn genetic sequencing is complementary to the current newborn screening program. So I think, we're not advocating, and it's unrealistic to think that the current biochemical newborn screening is ever going to go away. It's valuable, it's critical, that will continue. And so how do we start to plug in to that existing system in terms of, they've got some infrastructure already created for follow-up care. It is not perfect by any means, but it is something. And so maybe we can start to figure out a way to come alongside the public health labs, not only at a national level, but even at the individual state or local levels. How do we start to integrate some of these early projects and pilots? And we've got to start somewhere. So, my dream is that when we're at this conference next year, the conversation has changed. We've progressed. We're not having the same conversation over and over again, that we're able to move even a baby step forward, and pun intended. We're really advocating and moving forward, even at a small pace. The only way to move forward is to start moving.
Yep.
Can I just say D, all of the above? No, I really believe that Dr. Chung's example of increased access to telemedicine and telehealth is really what can drive more positive outcomes in states like mine. But then also, expanding our data collection, and how can we, in every level, how can we use this data as evidence for the things that we need everywhere else.
Well, thank you. Thank you to all of you for being a part of this today, and thank you especially to our panel for this discussion. And, we are very strong believers that our newborn screening system is working. We know that it is saving lives, but newborn screening can only save lives when we screen. So thank you so much for helping us support the enhancement and modernization of this system. Thank you.
Thank you, panel.